on the rising of COVID-19 infections and the fifth wave from Professor Musam Shabela, who's the Deputy Vice Chancellor from the University of KwaZulu-Natal, followed by questions and answers. Then the Deputy Minister, Dr. Songiseni Dhlomo, will do the wrap up and closing remarks. Without wasting any time, I'm going to allow the Honorable Minister, Dr. Joe Fatla, to take to the podium. Over to you, Minister.
Thank you very much, Mr. Mohale. Good morning to everyone on the platform. Morning to Deputy Minister Dhlomo. Morning to the DG and the team from Department of Health. To our special, guests, the Dr. Wasila Jasad from the NICD, and also Dr. Richard Lessers from the Genomic Sequencing Network, Professor Musa Mushabela from the Deputy Vice Chancellor from the University of KwaZulu-Natal, members of the media, ladies and gentlemen, good morning. Dumelang to all South Africans this morning. It's been quite a while since we shared with South Africans about how the pandemic, the COVID-19 pandemic, is progressing in our country and its impact on our lives. A major focus over the last almost 2 months has been on the exit from the state of disaster as the tool which we have been using in managing the pandemic. Over this period, there's been a sense of stability characterized by low infection rates, a low hospitalization, and also a very low death rates. At the same time, we've been witnessing very low uptake of the vaccination, unfortunately. During this time, the regulatory regime around the containment of COVID-19 dominated the public discourse in as far as COVID-19 is concerned. But at the same time, we continued to warn the public that this was not the time to lower our guards in as far as making sure that we can contain this epidemic or pandemic. And because part of that was that we've been noticing spikes of COVID-19 infections in other parts of the world, especially as many people will be aware, in the People's Republic of China, where there's been lockdowns in big cities such as Shanghai, and also seeing a lot of panic in other big cities such as Beijing and other parts of the world, including South Korea and parts of Europe. We've been seeing huge spikes of COVID-19. So we've been warning that while we're experiencing good stability with low infection rates, that we need to remain on the alert. Over the last 2 weeks, we started to notice a continuous rise in daily infections, led in the main by the provinces of Gauteng, Western Cape, and KwaZulu-Natal. The rise in daily infections took a sharper uptick as we got to the end of just the last week, the week which ended on the 23rd of April. And this uptick has been sustained during the week starting on the Monday of the 25th of April up to yesterday, reaching up to over 6,000 one-day infections on Wednesday, the 27th of April, which reflected on the tests which were done on the 26th of April, that is the Tuesday, just before the holiday. We then witnessed a slight decline to just over 4,000 infections on Thursday, that was yesterday, the 28th April. But we also are aware that this was tests which were done on a public holiday, on Freedom Day on the 27th. So we know that public holidays and weekends, the tests, the referral to hospitals and also to laboratories for testing is usually lower. So we take this with that kind of reservation. But what was important was that even then, the positivity rate remains quite high in the region of 17%. But in the provinces of Gauteng and KwaZulu-Natal, in the two, the positivity rate was actually above 20%. So we decided to wait a bit longer to observe this trend before we could communicate with the public, just to be able to have at least 14 days of observation to see whether this upward trend was being sustained or whether it was just something which was just for a moment. But the answer to that question is a resounding yes, that indeed over the last 14 days, the rise in infections have been sustained from just going over 2,000, 3,000, 4,000, up to reaching 6,300 in one day, as was the report on the Wednesday, which reflected a Tuesday test. Nationally, as of 25th of April 2022, there has been a 137% increase in new cases compared to 7 days prior, which is, when you look at the infection curve, it's a steep rise. This new steep rise was driven by higher rates of infection, as I've said, in Gauteng, in KZN, and also in the Western Cape. The three provinces, just on a daily basis, including yesterday, accounted for 85% of the positive cases of the country, and it was the same trend over the last 7 days. As of yesterday, when you look at so that is the 7-day average, but as you look even yesterday's result, Gauteng province alone accounted for 53% of the positive cases, KwaZulu-Natal 23%, and Western Cape 11%. So that actually gives you 87% of all the positive cases of the country. The positivity rate also quite worrying. In Gauteng, 23%, KwaZulu-Natal 23%, Western Cape 16%. The only new province which shot up in terms of positivity yesterday was the Northern Cape, which surpassed Western Cape at the rate of 18%. Active cases have risen from the lows of just less than 15,000 active cases in a day some weeks ago to 39,500 active cases yesterday. When we look at the R number, the reproductive rate, the reproductive number, this has also gone now above 1 as of yesterday at 1.56, which again is another pointer that we are indeed on the rise. The highest incidence per 100,000 of population is also in Gauteng at 76 per 100,000 population, followed by KwaZulu-Natal at 47 per 100,000 population, and the Western Cape at 46 per 100,000 population. So all these numbers point to a very steep rise in the rate of infection. So in terms of the rapid rise of infection, we can say that over the last 14 days, there's indeed no doubt about it. But what remains stable, even though with some changes, is the hospital admissions, including ICUs. Not a very dramatic change, but it has been noticed that there's been some change, which I'll come to the numbers. As of yesterday, the total admissions were again just over 2,000. Just 2,027, and those in ICU 192. So, but in absolute numbers, we have also seen some increase in admissions. For the week of April 18 to 24, there was an increase in admissions from the previous 7 days of 346 people admitted in the previous week. But on the week of the 18 to 24, this was more than double, at 808 people who were admitted in hospitals. Not yet very much threatening to the health capacity, the health services capacity, but indeed a trend which shows that there is definitely, as the numbers rise, also the number of admissions, although not at the same pace, also rising. But we also know from previous experiences that admissions and deaths are always trailing the high rise of infection. There was also a rise in deaths, not very dramatic, from a low base of a previous 7 days where there were only 51 deaths to the week of, again, the 18 to 24 of April, with almost a triple number of 156 deaths for that week. The question which is now on top of our minds is whether we have entered the fifth wave. As much earlier than we expected, because all along we've been expecting, as advised from our scientists, that probably middle of May or later in May or even early in June, we may enter the fifth wave. The question now on the top of our minds is whether, and as it's been debated in a number of media platforms, is whether indeed this fifth wave has commenced. Just amongst those who have been commenting on this, it's Professor Salim Abdul Karim, the previous chair of the Ministerial Advisory Committee, who issues a weekly email report in terms of his observation. And in this week, Tuesday, in his analysis, he argues that from a technical definition of more than 5 cases on a daily basis per 100,000 of population, with that as a criteria, he believes that we have entered the fifth wave, that in most of the provinces we have entered the fifth wave. But from another kind of a characterization of whether we are in the fifth wave, it is argued that we can only say that we are in the fifth wave if there is a sustained more than 6,237 cases per day on average over a sustained 7-day period. That will then tell us that we are indeed in the fifth wave. But whichever way you look at it, even from this kind of definition, as I've already alluded to on the Wednesday, the 27th, when we're reporting on the cases reported of the laboratory test of 26th April, we're already above 6,300. And there's just a dip from yesterday's report, which reflected tests done on the holiday. So whichever way we look at it, it does suggest that we may actually be entering the fifth wave much earlier. And we will possibly, we have to just wait for a few more days, maybe another 7 days, to can be very sure that this was not just a sporadic uptick, but it is a sustained uptick. What is also uncertain is, from our scientists, is whether, because we have always been informed also that when the new wave comes, it will be driven by a new variant. But at this stage, we have not been alerted to a definite new variant, except changes in the Omicron, which is now just a subvariant of the Omicron. So our scientists have been saying to us that a new wave will be driven by a new variant, which will be more transmissible and which will escape immunity. But at this stage, the variants which have been confirmed are the subvariants of Omicron, currently dominating being the B4 and the B5, which have some changes compared to the original B1, but not enough to be defined as variants of concern, because we are told that the changes are not that significant and they still bear the hallmark of the original Omicron. So this is also a question mark which we have to observe, and we'll listen. I'm sure Dr. Lassen will tell us more about this from the genomic sequencing. While these are the scientific analysis which the NICD and our colleagues from CRISP and the network will say more about, what is clear is that we are still at great risk of the COVID-19, especially as we go into a very long winter, as we can all see that we are just at the end of April, but we have already entered the winter. So it's going to be a very long winter where more people spend more time indoors, and where even our gatherings, whether for functions or even just for restaurants and other activities, will largely be indoors, which with the risk of high spread of any respiratory infection. Because of the lack of a clear driver of this spiking infections, there is also an analysis that because of the Easter weekend, which also coincided this time with the holy period of Ramadan for Muslims, and also the Passover for the Jewish faith, that there were a lot of religious gatherings, which also could have been the trigger for the spike which we have seen over the last 14 days, because this is also coinciding with just the 14 days after the Good Friday and the Easter long weekend. So the next 7 days until the 6th of May will give a clearer picture as to where we are going. That is, whether the fifth wave has started earlier without any distinct new variant, except for the sub-variant, whether the sub-variants will be the ones driving the early entry into the fifth wave, or whether it's simply gatherings as a result of the Easter weekend, as I've already alluded. Our message, notwithstanding this kind of uncertainty and further observation, but as we'll hear from the experts on the platform, our message again remains to say that COVID-19 remains a threat. It's not over, and we cannot afford to drop all the prevention measures. We do not believe that it is correct public health approach to say that because there is a lot of immunity, that is natural immunity and vaccine-driven immunity, we must just let the virus spread. We don't believe that this is the correct approach, because this will cause a lot of illness and a lot of distress amongst the people, individuals and families and community at workplaces. But also it will still have a very serious pressure on our health facilities and our health workers who have borne the brunt of this pandemic. We again urge all those who have still not vaccinated to come forward and take the jab. We are still under 50% of the adults who have taken at least one dose of the vaccination. We've been stuck at just under 50% in terms of the average of those who have taken at least one jab. And we need to get this at least up to 60% to protect us as we go into this very long winter. We especially urge our young people, those between the ages of 18 and 35, to come forward in numbers, because you need to protect yourselves and also protect the older people around you. We know that natural immunity wanes with time, and it cannot be boosted. It is only the vaccine-initiated immunity which can be boosted from time to time. And on this note, we also urge all those who have taken vaccinations, who are eligible for boosters, to please come forward and take their boosters. Lastly, in terms of the health regulations which we published, the commentary period has come to an end on the 24th of April. So now we are busy assessing these comments. We have received well over 300,000 comments, and we are taking all of those seriously. We are studying those, and once we have concluded, which we have to do before the 5th of May, when the disaster recovery regulations come to an end, we will then be able to announce on the regulations which we will promulgate. Thank you very much, Mr. Mohale, and over to you and the rest of the panel. Thank you.
Thanks very much, Honorable Minister, for that update. Indeed, the lifting of the national state of disaster does not mean COVID-19 is over. So without wasting any time, I'm going to call upon Dr. Wasilia Yasat from the NICD to give us the epidemiology report of the COVID-19. Over to you, Doc.
Thank you so much, and good morning to the Honourable Minister and all the guests and the participants today. I'll be presenting on behalf of my colleague, Dr. Michelle Groom, and others at the NICD, combining both the epidemiology and the hospitalization update of this latest COVID-19 resurgence. So we know that globally, after the steep Omicron wave, there was a secondary wave of probably BA.2 across the globe that caused another a peak. But since then, cases have been on the decline across all regions. However, in South Africa, we've been noting an increase in the percentage testing positive for about 5 weeks, and a very rapid increase from week 14 to 15 and to week 16. And currently the percentage testing positive at almost 18%. We've noted that percentage testing positive has increased in every province, with a very sharp increase in the last week, and the highest percentage testing positive being in Gauteng, KwaZulu-Natal, and the Western Cape. We also started to see an increase in the weekly incidence risk of SARS-CoV-2 cases in all provinces, the highest being in Gauteng, followed by Western Cape and KwaZulu-Natal. However, all provinces have started to show increases in the incidence risk for cases. When we look at the week-on-week change in cases in blue and admissions, hospital admissions in red, you can see this picture in the first 3 waves. We didn't have very rapid, huge increases week on week in cases and admissions. But in the 4th Omicron wave, we saw that very rapid incline to a very quick peak in cases and a less rapid incline in hospital admissions. In this secondary increase now in April, we are seeing again a week-on-week increase in cases that is very rapidly increasing, with a smaller increase in hospital admissions. So this graph, I think, was quite telling during the 4th wave and showed that picture of the decoupling of cases and admissions in the 4th wave, which was different from the first 3 waves. So currently in this resurgence, we are seeing increases in cases and a much smaller level of increase in hospital admissions, and we are seeing no increase in deaths at the moment. The South African Medical Research Council reports weekly on excess deaths that are over and above the projected number of deaths based on historical data. We saw in the 4th wave that there were less increases in excess deaths than we saw in the previous waves, in line with the Omicron wave having lower severity. Currently, we're not seeing any huge increases in excess deaths. When you look at the weekly deaths from natural causes of people 60 and above, it is just above the upper bounds of normal. However, we also note that between the other waves, we also saw excess deaths from natural causes in those 60 and above, just above the upper bounds. So that increase is something we'll just continue to watch to see if that does translate into increases in excess deaths during this resurgence. In terms of hospital admissions, we'll look at the hospitalization picture in a bit more detail. On the left, you will see that we are starting to see a small rise in hospital admissions in the private sector more, and then also slightly in the public sector. We're starting to see increases in the 7-day moving average of admissions in a few provinces, most notably in Gauteng and KwaZulu-Natal. When you look at that in more detail, just from with a graph isolated from the 1st of March, you can more clearly see that since about the 17th of April, we are seeing a sharp increase in hospital admissions. On the left, you can see in Gauteng and KwaZulu-Natal particularly. On the right, you can also see an increase in Free State, Mpumalanga, Limpopo, and Northwest as well. We are seeing no increases in deaths. This is in-hospital reported deaths in either the public or private sector or in any of the provinces at the moment. When we compare the daily average of admissions in the last 7 days and the previous 7 days, you can see that increase in admissions in Free State, Gauteng, KwaZulu-Natal, Limpopo, Mpumalanga, and Northwest. We're not really seeing any very big worrying increases in deaths just yet. But what I also wanted to point out to you here is that you can see that the daily averages of admissions are still quite small in most provinces, the highest being in Gauteng of 60 admissions per day, knowing that in the peak of the Delta wave, there were 1,000 admissions per day. So we're still at very low numbers, but there are increases in hospitalization. So now on to looking at who is being infected in terms of age groups. When we look at the percentage testing positive, you'll see the earlier peak of the Omicron wave in November, December. And then you see that secondary increase and peak of the younger age group of school-going age. And that was in late January, just after the schools reopened. That peaked quite quickly and began to settle and just about returned to normal, to similar levels as the other age group when this increase began. And you can see that the current increase affects all age groups. The highest percentage testing positive is in the 10 to 14 age group, and the lowest being in the very youngest, the 0 to 4. In terms of cases, you will see that the increase in this current resurgence, the weekly incidence for SARS-CoV-2 cases affects all age groups. On the right, you can see more clearly, just isolating the last 8 weeks, the highest incidence risk for cases is in those 40 to 59 and over 60, so in the oldest age groups, followed by 20 to 39, and then the younger age groups, children under 20. However, there are increases noted in all age groups, including children. In terms of the number of admissions that have been reported since the resurgence began, it's just under 2,000. And most admissions have been, unlike in the first three waves where more admissions were in the older age group, what we saw in the fourth wave was that more admissions were in those under 40. And now we're seeing again that there's a high number of admissions in younger people, and particularly in children under 4. With lower numbers of admissions in older people. But this is the absolute number of admissions. When you look at this as a risk, the incidence risk, which is the number of admissions over the population size, you can see that across all waves, incidence risk for admissions increases with increasing age. So the very oldest are most likely to be admitted, followed by the 50 to 64, then the 35 to 49, and so on, with children least likely to be admitted, having the lowest incidence risk. However, in the fourth wave, we did see a higher incidence risk for those 20 to 34 and for children under 20. So currently, in the last 8 weeks or so, we have started to see increases in most age groups. The highest incidence risk for hospital admissions is still in the oldest age group, over 65. It's very early, and I just wanted to make a disclaimer that it's too early to make any comments about severity because this resurgence has just begun about 2 weeks ago. We've just started to see an increase in hospitalization. So I will continue to present this data over the coming weeks, and it will start to look clearer. I wanted to show you the proportion per month had severe disease who were admitted to hospital. And at the peaks of each wave, we saw higher severity. During the Omicron wave here in November, December, we saw a lower severity than at any time previously in the pandemic. And now in April, during this current resurgence, we're still seeing a low level of severity, around 25%, and we haven't started to see increases in deaths or severity. There's a small increase in the number of people who need oxygen and ventilation, but we haven't seen any real increases in the proportion who are severe. I wanted to also remind you that our Sentinel surveillance studies at NICD have been picking up other pathogens as well. We had a respiratory syncytial virus season appear that maybe didn't appear in the last 2 years and has now peaked sort of around week 13, but our surveillance are picking up a fair number of cases of RSV. We also have had sporadic cases of influenza as well. And so given the winter season and the time for the circulation of other pathogens, it must be borne in mind that along with the current resurgence of SARS-CoV-2, we also have other pathogens circulating. So just in summary, we are seeing globally a decrease in case numbers in all regions, but some cities are starting to see increases. Dr. Lessels will talk about the genomics surveillance here in South Africa, but we're starting to see BA4 and BA5 increase in prevalence from 16% in March to 44% in April. Our wastewater surveillance have shown small but sustained increases in Gauteng, KZN, Free State, Western Cape, Northern Cape, and Northwest water plants. Now we are reporting increasing percentage testing positive cases and hospitalizations, although no increases in deaths or excess deaths just yet. And I think the minister has given a good explanation on, the complexities of calling this a new wave or just a resurgence. But it's something that we continue to watch over the coming weeks. Just in terms of the differences by provinces, in terms of the percentage testing positive and the incidence risk of cases and hospitalizations, Gauteng most affected, as we saw in the first Omicron wave, along with KZN. And in terms of ages, all age groups are increasing in percentage testing positive, although the highest being in the 10 to 14 years age group. And in terms of cases and admissions, the incidence risks are increasing with increasing age. So the highest risk of cases and admissions are in the older groups. Just in terms of some actions, I think it's very important to continue the genomic surveillance to monitor for any new variant of concern that might emerge and for the sort of prevalence of these Omicron sublineages. In terms of testing, we have no reason to think that the sensitivity of the PCR tests is affected at the moment. And I think because of the circulating pathogens, clinicians should be advised to consider testing for other pathogens as well. We need to very closely scrutinize and monitor hospitalizations. At the moment, there are no indications that there are increased severity, but of course, we need time, we need a few weeks for those trends to develop, and that's something we'll continue to report on. And also at the moment, there's no pressure on hospital beds or oxygen, but our provinces are on high alert for surge preparedness to ensure that they are prepared with beds and oxygen should the increases materialize. I think the research has conclusively shown that even if there is some loss of immunity with new variants or with subvariants, vaccinations do still protect against severe disease. They may not protect against infection, but they protect against severe disease. And so I think it's absolutely important for people to vaccinate if they haven't vaccinated, to boost if they've vaccinated a while ago, because many people have waning immunity because they vaccinated quite a while ago or have been infected possibly in earlier waves and have had waning immunity. I think just to emphasize for the public out there in terms of if you have symptoms, most importantly is to isolate and to avoid passing on the infection to others, and to note the signs of deteriorating illness so that you can seek healthcare early. Thank you so much.
First, you're muted.
Okay. Oh, sorry. Thanks, Dr. Wasila Yasat, for that good presentation. Indeed, we can mitigate the impact of the current subvariant if we do the right thing to protect ourselves. And the most important thing to do is to vaccinate. So without wasting any time, I'm going to call upon Dr. Richard Lester to give us the genomic report. Over to you, Doc.
Thank you, and good morning, Minister, Deputy Minister, DG, DDGs, and colleagues. Nice to be with you this morning. So, as the Minister said, I'm talking on behalf of the Network for Genomic Surveillance in South Africa. So, and just to highlight that many people are still working hard behind the scenes in all our sequencing labs and our colleagues in the diagnostic labs, still working hard to track this virus and how it's changing over time. And so what I'm going to just present to you this morning is just to highlight that, as you know, the Omicron variant, what we call the Omicron variant, is a family of different lineages. And originally, when we first identified it back in November, December, there were these three lineages, BA1, 2, and 3. We've now identified these two additional lineages, which have been called BA.4 and 5. And although these are similar, particularly to BA.2, there are important differences in these viruses and some important additional mutations. As has been highlighted already by the Minister and by Dr. Jasat, our genomic data, as well as some of the PCR testing data, suggest that these lineages are responsible for an increasing share of the cases in South Africa, and that they're taking over from the BA.2 that had become dominant. And then again, as highlighted by the Minister and Dr. Jasat, there's now consistent indicators that this is associated with a change in the epidemiology. So just to highlight here pictorially, this is just a graphic of what we've seen with the 4 waves of this epidemic in South Africa. We've seen from the second wave onwards, these variants of concern, first the Beta, then the Delta in green, and then this Omicron variant from November, December. What we sometimes forget is that even within this Delta wave, there was quite a lot of diversity of that variant. So there were multiple lineages of the Delta variant that circulated during this wave. What we know with the Omicron is that most of the early infections in December and early January were likely caused by the BA.1 lineage. So that was the dominant variant in the first phase of that 4th wave. Then we saw the BA.2 take over from the BA.1. But that didn't cause a significant resurgence in infections, in cases, in hospitalizations. It prolonged the wave somewhat. And that's what you see here is this kind of, that we didn't get down quite as low as we'd got after that Delta wave. So there was some prolongation of the wave. And what you see now is this BA.4 and 5 coming in. This you'll be familiar with from previous presentations from Tullio and myself, that here we just look at, of all the samples that we sequence, what proportion are the different lineages. And here we're just looking from November last year. So we're just really looking at the Omicron wave. And here you just see nicely this pattern that, as I said, in December and early January, it was dominated by BA.1 in the pink. And then in blue, this is the BA.2 that really took over and replaced the BA.1. And what you see now since early March is this growth of the BA.4 and 5 together. And that's the yellow and the orange here. And you can see that really since the beginning of April, they've now been kind of around 50% and now slightly more of all the samples that we sequence. We also get supportive information from some of the PCR testing data that's done by the NHLS and by the private labs. And here, this is some very nice monitoring that's done routinely by the NHLS, led by Professor Wendy Stevens and Professor Leslie Scott and their group, where they continually track this proxy marker that we call the PCR S gene target failure. And this is just a quirk of some of these variants, some of these lineages, that they have a mutation that allows you to identify it on the PCR test. And what we saw in November, December was that we saw this proportion of the positive tests that had this signal go right up to almost 100%. And that was because of the BA.1 lineage. Because the BA.2 lineage didn't have this marker, we then saw it return to almost 0%. And now what we're seeing is this increase again since early March, up to 50, 60, 70, 80% or so. It depends a little bit which criteria you use, but that's not important. So this gives us confidence that what we're seeing in the genomic data is matched by the PCR testing data, and gives us confidence that it is these BA.4 and 5 lineages that are associated with the increase in cases. As you know, we sequence samples from all around the country, but often when we get a resurgence, we're initially focusing on where that resurgence is happening most obviously. And so what you're seeing here is we've detected these BA.4 and 5 in most of the provinces. You can see here that we're seeing more of it in Gauteng and KwaZulu-Natal, and also to some extent Western Cape. And the fact that we haven't identified it in Northern Cape and Free State is really just because we're a bit behind with getting samples from those provinces. So the basic message is it's likely to be spreading all around the country, these new lineages. This is the technical details that some people obviously follow closely. The key thing is that BA.4 and BA.5, the reason we're grouping them together is that they have identical spike mutations. So the only differences between 4 and 5 are outside the spike protein. And we're not sure if they will have any major significance in terms of the properties of the virus. So we're happy for now to group these together and consider them quite similar. The closest sister lineage for these two is BA.2. So these are quite similar to BA.2, but even then there are some important differences, and these are highlighted in red here, these additional mutations compared to the BA.2. But what I want to highlight is that these are then quite different from BA.1. And so when we think about these variants and these lineages, we sometimes get a little bit confused because there's a lot of diversity within this Omicron family. So if we compare BA.4 and 5 to BA.1, they are quite different. And they are probably, for example, as different as the beta variant was to what had come before that. And I think that that helps us to explain why we might be seeing some resurgence in the cases now. Again, just the technical details, why these mutations might be at important positions in this spike protein. We know that these are important positions, again, most importantly for immune evasion, for getting around some of the antibody immunity. But as we've said before, at this time of the pandemic, as we see all these complex changes in the virus, it's very difficult to predict exactly how this different pattern of mutations will affect how the virus behaves. And what we need to find out now is exactly what is the pattern of how it evades the immunity. And as Dr. Jassed said, whether there's any evidence that it changes the disease severity. Just want to highlight that by now, as you know, there's a very complex mix of immunity in South Africa that's acquired from the vaccines and from infections with all these different variants that we've seen over the 4 waves. It's quite likely that this growth in these new lineages might relate to a different capacity to get around some of the immunity against infection. And it may be particularly this difference from BA1 is allowing it to get around some of the immunity that was acquired from BA1 infection in December, January. And in that sense, the other really important thing is the waning immunity. And here we're talking about waning immunity against infection, which happens quite quickly. And that may also be contributing to what we're seeing now in terms of this resurgence. What's always critical to remember, and the others have highlighted this, is the immune protection against severe disease is different from the immunity against infection. It brings in many different parts of the immune system. The waning is less prominent, and it's much harder for the evolving virus to get around all the different layers of the immune protection. So as has been highlighted by the minister and Dr. Jassed, the key public health measure against all these variants and all these lineages will always be vaccination to prevent severe disease. And that's regardless of whether you've been infected before, one time, multiple times. You still need to go get your first, second, third dose, whichever you are due for. So just to summarize again, the Omicron variant is a family of different lineages. We've now identified 2 new sister lineages in this family. And although they're similar to BA.2, there are important differences. And when we compare it to BA.1, those differences are quite significant. We see that these are growing in South Africa and are taking over from the BA.2. And it's now consistently seeing that this is associated with a change in the epidemiology. As always, we've been working hard behind the scene to put this all together and to submit this to our scientific peers. And so there's a manuscript that's been submitted for peer review. And for now, this is available at the CRISP and the SERI websites. So for anybody who wants to dig into more details about this, you'll find the paper on those websites. And so just to thank, as I said, all the people that continue to work hard behind the scenes in the sequencing teams around the country, and particularly thanks for the support of the Department of Science and Innovation and the South African Medical Research Council for continuing to support the genomic surveillance, which is allowing us here in South Africa to continue tracking how this virus changes over time. And you'll be aware that in many parts of the world, some of this surveillance is really stepping down. And we should be proud in South Africa that we're continuing to support this and continuing to do the surveillance and do the science to understand this virus. So I'll stop there and thank you.
Thank you, Dr. Richard Lessing, for that good presentation, and thanks to all the team members who have contributed to that. They will continue to work very hard behind the scenes to track these variants and the virus. Without wasting any time, I'm going to call upon Professor Mosamshabela, who's the Deputy Vice Chancellor from the University of KZN, to take us through the rising COVID-19 infections and the fifth wave. Over to you, Prof.
Thank you so much, Foster. Are you able to hear me?
Yes, loud and clear.
Excellent. Thank you. Yes, thank you very much, Honorable Minister, Deputy Minister, and DG. I'd like to pass my warm regards and thank you kindly for the invitation to share my thoughts on this. And also really just for the fact that we are now actually engaging with the media and South Africans, and we are able to actually allay some anxieties that might be out there, and recognizing that, of course, we are still navigating a lot of uncertainty. I also just want to greet other members, officials of the department, and my colleagues who are present from various research institutions and academic institutions, and everyone who is listening. Minister, I am going to share what I think is more of a public health perspective, and some of these things you have already alluded to, and I'll just try to highlight what I think is important for us to recognize. I think that by now, up to, given the presentations that have come before, we can clearly see that we are dealing with an increased burden of COVID-19. And yes, we may not have a completely new variant, which is something that most people expect to see, but we do have a problem. And I think Dr. Lessels has adequately captured why, even though we are dealing with a subvariant, these subvariants are still important in potentially driving the infections that we are seeing currently. We also have a number of thresholds that the minister alluded to in terms of 5 cases per 100,000 that Slim often refers to, Professor Abdul Karim, as well as what the NICD normally talks about, which is 30 cases per 100,000 weekly incidence cases. And also the Honorable Minister referred to the 30% of the previous peak that we often want to wait until we reach. But we've seen in terms of this indicator that it takes a while. It makes us wait too long before we actually declare a wave. And by that time, infections could be running amok. And it's important that we also use some of the metrics that are quite a little bit more sensitive. The WHO also uses the positivity rate cutoff of 10% to indicate that we are seeing a wave. And we are now at 17.7%, as Dr. Jasad has already indicated, which also means that it's an indication that we have entered into a wave. But it's important to also recognize that in that presentation from Dr. Jasad that, we never really went below 6.1%. We never really reached below 5%, as is often expected with the positivity rate between the waves. And I think that Dr. Lessels has adequately captured that. That was driven largely by BA2 variant, a subvariant. And often with the data that we've looked at previously, most of this was seen in the Western Cape. And you can actually see in the graph that Dr. Lessels showed. Now, in terms of hospitalizations, it's still small, but we are seeing a visible increase. And hospital deaths is still very minimal increase, but it's starting to emerge. And I think that the minister referred to this. And excess deaths, as Dr. Jasad showed, we don't have a clear increase as yet. So in a way, what this means is that we are still in that space of flux where the trajectory is still going, but the trend is still clear and it's emerging, and we need to work with what we've got. And it is true, I agree as well, that I think another week will probably add a lot of value in terms of clarifying many of these trends. But as we know, waiting a week before we take action can also get in the way of some of the important interventions that people can put in place to protect themselves. This is the slide that actually shows you the cutoff point for 5 per 100,000 in terms of 7-day moving average. And you can see that the 3 provinces that colleagues have referred to, Gauteng, KZN, and Western Cape, have breached this, and they are the ones currently in terms of numbers driving the numbers in the country. But also, as we know, these are the biggest provinces that we have, that we often see, and sometimes the Eastern Cape is also part of that. Now, there is a debate that I think the minister alluded to in terms of whether we are in the COVID-19 wave or not. And really, this is a technical discussion about whether we have a sustained trajectory or not, or unsustained trajectory. And I think for me, what's important is that the debate really focuses on short-lived exposure that may have arisen after the weekend, the Easter weekend, and the minister alluded to that. And also we saw that BA2 resurgence, which was also short-lived, and colleagues are worried that what if the BA4 and 5 might be short-lived as well? We need to see a clear trend. And also the fact that we have a very delicate balance of immunity, and that might also help in terms of curbing the trajectory. And so all of these points are valid, but at the same time, I think that we have to recognize that this is the first resurgence we are seeing since the ending of the state of disaster, and this ending of the state of disaster came with reduced restrictions. And also, this is the first time we are seeing a resurgence really driven by what we see as a sublineage or a subvariant. So we will continue to monitor, and hopefully in an update that we'll be seeing in a week's time, that can also give us a better indication of the trend. Now, I think here we often talk, in our minds, we tend to want to simplify things, and we often look for the one thing that's driving the resurgence or the wave. But the reality is that these waves and resurgences are driven by a complex interaction of different things. I think that the minister alluded to a lot of things that may relate to behavior, and I think Dr. Chesat has also done that. But also, as Richard has indicated, that there are variants that are also interacting with a complex interaction of immunity. So all these three things are interacting at the same time. And this is also why when we think about how to control the pandemic and the spread of infections, we need to think about how we are influencing these different areas. Yes, we may monitor variants and we may be able to use them to explain infections, but there's a lot that people can do in their own behaviors every day in terms of protecting them from exposure or seeking healthcare and so forth. And we also recognize that all of this happen in a particular environment context, like when it's cold, now people may be gathering indoor and not ventilating properly. And this might actually increase the airborne spread of COVID-19. And likewise, we may find that we are changing policies, and there are other events that are happening in the country that may drive the infection in our environment. So I do want to emphasize that I think in South Africa, the approach has been to use containment, which tends to help to prevent the spread of infection, versus what we see as mitigation, really responding to cases that we may see. And ever since we ended the state of disaster, we've been talking a lot about this notion of personal responsibility, because essentially what it does is that government is no longer able to influence as much using the legislation, the behaviors of people. Now this becomes the responsibility. So therefore, if you think about it, it means that the responsibility to prevent infection and to protect yourselves from exposure lies with the individual and those around them. And the state will continue to be responsible for the functioning of the healthcare system and protect the health system from excessive strain. And all of this then means that we can then be able to see two things happening at the same time. Oftentimes when I listen to conversations and I have engagements with people, I find that people often just simply talk about mitigation. And I think that, as the minister said, that we must not abandon prevention. In as much as we don't want and we don't have the resources and we don't really want to implement lockdowns or alert levels, most people are fatigued by all of these things. We don't want them to be imposed, and we agree that they shouldn't be imposed, but it does not mean that they are no longer necessary. All these public health and social measures are important. Dr. Jasad mentioned the importance of self-isolation. Self-isolation, whenever someone is having respiratory symptoms, it's important that you stay home, you don't go to work and end up infecting other people, or you wear a mask to make sure that you don't spread that. These are responsibilities that we have in terms of protecting ourselves and protecting others. So I do think that we need to ensure that containment continues. But Honorable Minister, I should also add here that I think that we have not given South Africans all the tools they need to make sure that they can contain this. I think vaccines are available, it's an important tool, but I think they may need other tools. For example, when it comes to navigating symptoms and they don't know whether it's flu or it's COVID, or in terms of whether when they are sick, how to respond to those, whether to seek healthcare, all of those indications in terms of what is it that people need to do, perhaps is something that we need to clarify with South Africans. But I do recognize that there are these two parts that involves the role of the state as well as the role of individuals. I also want to just highlight an important problem that we've been seeing around long COVID. And in South Africa, we haven't spoken much about this. There's not a lot of groups that are studying and monitoring these trends in South Africa, but there are some people in the Western Cape who have started looking at this, and some in the Eastern Cape. But patients are being treated. A lot of doctors, infectious disease doctors, are treating these patients with long COVID. And essentially what this is symptoms that continue or develop after acute COVID-19 infection and cannot be explained by other alternative diagnoses. And they may include symptomatic COVID-19 from 4 to 12 weeks post-infection, and also post-COVID-19 syndrome beyond 12 weeks, as you can see in this graph. Now, the symptoms of it means that COVID-19 can then end up with short illness experience, but for some people, it can become a long illness experience, where the old symptoms that they had during COVID-19 will persist, and in some cases, they develop new symptoms. And it's important to highlight here that even when people have had mild infections or mild disease and did not need to go to hospital, they can still develop long COVID. And there's been many reports around this issue. Now, in terms of COVID-19 itself, people think that it just affects the lungs, but it affects many parts of the body. It's a multi-organ disease, as you can see from this diagram. When people have long COVID, they often talk of feeling tired in their muscles. They talk of brain fog. They also talk of palpitations or difficulty breathing. All the symptoms have to do with the fact that many of these body parts have receptors that can also pick up COVID-19. And the mechanisms, of course, of how long COVID actually works are still being studied. And there are many hypotheses, but it's important for people to understand this. And I want to highlight here that if someone did not test for COVID-19, they had COVID and it was mild, they then develop long COVID, and they may not know that the symptoms they're experiencing are because of COVID-19. And we've seen people with symptoms consistent with long COVID thinking that it's because of the vaccine. And it's important to distinguish this, which is also why I think that there should be some place for people to be able to know when they've got COVID-19. Dr. Jasad mentioned the issue of co-infections, and I think this is also a growing problem in the literature. We are seeing that, potentially COVID-19 can impair immunity, and if it impairs immunity, we may end up with a situation where other pathogens can increase severity of disease in patients with COVID-19. And as Dr. Chisat said, that it's important for us to test for both, and it might be co-infection or super-infection. In either case, we must not take it for granted when we diagnose COVID-19 that a person may have only COVID-19. And I would appeal also, Honorable Minister, that we pay attention to this problem. It is also a growing problem. The last issue I want to mention, Minister, is the importance of protecting the most vulnerable. I think that we have entered a stage of the pandemic whereby many people have immunity, but some people have still not vaccinated, as you indicated, the 50% of adults. And I'm concerned that potentially the many people that have not vaccinated, these are people with vulnerable factors, or who are vulnerable in our society, either socioeconomically, the people who are poor, but it may also be people who are, for example, immunosuppressed, or people with comorbidities, people who are homeless, disabilities, and so forth. And I do think that we need to be able to tailor our approach to be able to target these individuals. I think the department has done a good job of targeting people when we segment by age group, but I think we need to go further to start to segment the population in terms of their vulnerabilities and target them. This will require interventions that are closer to the community, closer to the people and on the ground, and we may have to make sure that we work, for example, with health works, with education and social development in providing integrated approaches. This is the last thing that I wanted to mention, Minister and colleagues, and therefore these targeted policies and actions, I think that will take us forward in terms of protecting people who are at the greatest socioeconomic vulnerability. In conclusion, I just want to say that for all intents and purposes, we have entered the fifth wave, and we need to treat it as such. In as much as we are still continuing to monitor, we cannot stay in paralysis and not act. We need to make sure that we bring forward the necessary interventions, we bring forward the necessary messages. We are prepared to deal with what may arise, and it's better to be over-prepared than under-prepared. I think that the drivers of the rise in infections are complex. The behavior is really important in this regard, the variants and the immunity, where it's present, including people who are vaccinated and boosted. This will help to protect people and mediate the effect of the variants. But behavior really is going to be important. And as I said, this is now personal responsibility, even though I think that we need to make sure that tools are available to support individuals. And also we've noted the ending of the state of disaster, and it's the first time we're having to face a wave without the state of disaster. And we still need to ensure that the government and the state will protect the integrity of the health system. And the rest of us, we need to make sure that we protect ourselves and one another. And as I indicated, the importance of protecting people from the effects of long COVID, the core infections and super infections, as well as ensuring that we can target services towards the most vulnerable. Thank you, Minister, and I'll hand over back to you, Foster.
Thanks very much, Prof. Mshabela, for that great presentation. Indeed, we don't have to lower our guard because we're still living with COVID. So now I'm going to open for a floor for questions and answers. We have received only very few questions. Maybe it's because the message was loud and clear from both the minister and all other presenters. So I'm going to quickly take these questions, unless the others, there are follow-ups while we are dealing with these ones. The first question reads as follows: how many people have been reinfected with COVID-19? Are the studies being conducted to see if there are factors that predispose to some people to get COVID-19 more than one since November and December 2021? The second question reads: the department is working against the deadline of May the 5th to process and finalize thousands of public comments on the health regulations. Are you confident that we'll be able to meet the deadline? If no, what will happen? Is there any option to extend transitional measures as announced by COGTA Minister? The third question: how ready is the department in case the current situation does not improve in terms of hospital capacity? As we know that the more the number of cases, the increase, it also affect the capacity of the hospitals. The fourth question, is there any chance that additional boosters will be introduced to everyone, not just immunocompromised people? Question number 5, under state of disaster, the pandemic was controlled through lockdown levels, level 1 up to 5. How is the department going to do this under health regulations? Last question. Lots of people say they would rather take an inactivated virus vaccine like Sinovac because technology is tried and tested. And we are getting many questions as to whether Sinovac is going to be made available in South Africa. Can you please provide an update on that? Minister and members of the panel, this is the first batch of questions that we have received so far. I'm going to hand over back to Minister to allocate these questions. Over to you, Minister.
Well, thank you very much for that. I don't know if I'm audible. My internet says it's weak. So can I just hear from you whether I'm audible?
Yes, Minister, you're loud and clear.
Okay. No, thanks a lot. I won't take long because of this risk of a weak internet. I would suggest that the one I'm not confident that I had all the questions. The one on reinfections and predisposing factors. I'm wondering if Dr. Jassat could help us with that. And then, okay, I think I've got, yeah. If DG could deal with the deadline on the public comments. I think there was a question, yeah, the deadline, if DG could deal with that. How ready is the department in terms of dealing with if the situation does not improve? I think on that one, maybe Dr. Crisp could deal with the readiness of the health system, or DG, you could allocate somebody else if between yourself and Dr. Crisp, you could decide on the health system's readiness for a 5th wave. Boosters, additional boosters, Dr. Crisp will be quite relevant to deal with that. Lockdowns during disaster, what are the other health regulations? I think between the two of you, again, you can decide on that. Lots of people would rather take an inactivated virus like Sinovac. Well, I'm sure in terms of maybe I know that Richard is more on the genomics, but just in terms of maybe you could also get into the one on the different vaccines between the inactivated virus and also the messenger RNA. I think the question was to suggest that there are people who are quite suspicious of the efficacy of mRNA rather than the old tried and tested inactivated virus. Let me leave it there. I've given some guideline, but I'm sure colleagues can share some of the matters. For that, maybe let's, if Dr. Jassat is happy to tackle the one on reinfections and predisposing factors, and then DG and the team, including Dr. Richard Lessers, can also help on the others. Over to you, Dr. Jassat.
Thank you. In the early Omicron wave in November, December, we did report an increase in reinfections because that variant had a propensity for immune escape. At the moment, we're not really seeing an increase, but I think it's still early and we'll continue to monitor for that. I'd like to ask Prof. Cohen to weigh in here because she's got some interesting studies from the NICD where she can share some findings, particularly on the reinfection risks. Prof. Cohen?
So thanks very much, and thanks for having me on the panel. Yes, so just to agree with Dr. Jassat, I think the question has two parts. The first one is really with this resurgence and increase in cases that we are seeing, is there an increase in reinfections? And as Dr. Jasset mentioned, we monitor this, and right now we don't see an increase in reinfections. This would be important because if we do see reinfections, it suggests immune escape, which is probably happening to an extent, as Dr. Lessel said, but so far not a strong signal. In terms of who gets reinfections, I think our data suggests it's really very similar to who gets infections in the first place. So as Dr. Moshabela showed in that infographic, there are lots of different factors. The one is exposure. The more you're out there being exposed to COVID, the more chance of having a reinfection. And then the others are really around immunity. And so it's really the degree, as we've seen, previous infection and vaccination can wane in terms of its protection. So it's really how much immunity you have at that point in time in relation to the circulating variants, which escape that immunity. So and of course, people with a weaker immune response who haven't been vaccinated are more likely because they have a lower immunity. So it's really that combination, and it's not very different from the initial infection. In fact, most South Africans do have immunity. About more than 80% of South Africans have some level of immunity. So really, preventing reinfection is the same as preventing infection, which is getting your vaccine and then wearing masks and limiting your contact, especially now as we see an increase in cases. Thanks.
Thank you very much. Thank you very much, Honorable Minister, and thank you very much to the colleagues. Firstly, on the issue of the analysis of all the public comments, we've got a fully fledged operations center that are working around the clock, and we do have quite a high throughput in terms of the analysis, and we are very comfortable. We talk almost every day with the leadership of the operations room, and we believe that we will be able to meet the deadline. We are aware that there were limited legal options in terms of going beyond the 5th of May. Hence, we've been working weekends and holidays. So we are comfortable, as the Minister mentioned. We're pushing, the team is hard at work, and also increasing the throughput in terms of the analysis. In terms of the facilities, we are also very comfortable in terms of what's happening in the facilities. We monitor through the DATCOV system, as Dr. Jasset was mentioning, and we know that we have enough capacity. When we start seeing some serious warning signs, we're going to try and see how we increase that capacity. But we believe that the health system is ready, but it doesn't mean that we shouldn't be moving towards the containment. We don't really want people to end up in hospitals, but should that happen, we are comfortable that with the facilities, we are quite ready to deal with those issues. And then there's a question, I will allow Dr. Chris to come in on the boosters, and also then Professor Lessels. But I would like to say that I think question 5 is talking about what will we use outside of the state of emergency. And as the Minister mentioned, and has mentioned several times in the past, we are going to be using our health regulations that we believe should be promulgated at the time that the post-state of disaster recovery regulations are actually expiring. Thank you very much. I'll request Dr. Chris to come in.
Thank you very much, DG. Good morning, Minister, Deputy Minister, colleagues and media. So as far as extra boosters are concerned, this has been a matter of some discussion in the Vaccine Ministerial Advisory Committee recently, and they have specifically tabled the matter and are collecting data for the evidence of either the impact and the need for additional boosters, and will advise us in due course. We don't want to give boosters just because we've got vaccine. We want to give it because it's useful. It does create extra work for the health system, so you want to make sure that you are using the vaccine appropriately. For now, the additional doses are given to people who are immunocompromised and people who have specific medical conditions. But we'll wait, and we will get some guidance from the Vaccine Ministerial Advisory Committee on that quite soon. As far as the last question was concerned about the different types of vaccines, so we have 2 vaccines that we've been using from the outset in South Africa. The one is the Pfizer vaccine, which is an mRNA vaccine, the one that is a newer technology, and I won't go into the details of why it is different, but it's not completely new. The technology has been used for a long time in other diseases and has been under investigation in this country by our scientists for some time. So it's not entirely new to us, and now we have a lot of experience with hundreds of millions of doses of this vaccine being used. So we are confident that it works, it's effective, and it doesn't have the side effects and impacts that the naysayers are concerned about. We do also use Johnson & Johnson vaccine. It is different. It's not an mRNA vaccine. It's what we call an Ad26 in this case vaccine. It's built on an adenovirus, which is a technology we've used for many years. I'm sure that Dr. Lessels can expand on this. But it's a well-known technology that's been around for a very long time and is used in other vaccines. So we believe we have two very good vaccines. We have millions of doses of these vaccines already procured. So we're not in a hurry to procure any other kinds of vaccines, just to make available, the different kinds of vaccines that are there. Most countries use one or maybe two, but very few use more than two vaccines. So the answer is no, we're not intending to add another vaccine at this point. Thank you, DG, unless Dr. Lessels wanted to add.
I mean, completely agree with what Dr. Crisp said. I mean, really, when we talk about tried and tested vaccines, we must acknowledge that these vaccines we're using in South Africa, these two different vaccines, are now very well tried and tested for this virus. Billions of doses of the Pfizer vaccine given around the world. And really, we know that they're remarkably effective at keeping you out of hospital, keeping you off the ventilator, off the oxygen. And that effectiveness has held up against this changing virus. And so regardless of what some people will try and tell you, these vaccines remain highly effective at preventing severe disease, which is what they're designed to do. And really, we know from the evidence we have that there's no advantage to the Sinovac vaccine, which was mentioned. And actually, there's a concern that the effectiveness against severe disease may not be quite as good as the two vaccines that we do have in use in South Africa. So as Dr. Crisp said, there would be no public health kind of rationale for replacing the current vaccines or adding in the Sinovac vaccine based on the evidence we have at the moment. Thank you.
Thank you, Dr. Lessels. Let's hand back to you, Foster.
Thank you, DG, and thanks to Minister and colleagues who have responded to the first batch of questions. Now we've experienced a surge of media questions. So now we've got about 10 follow-up questions. I'm going to quickly take them as one batch. The first question reads as follows: will boosters be made available to 12 to 17-year-olds rather than allowing Pfizer vaccines to expire? Second question from Christian Duplessis: do we know how many people suffer from long COVID and is it curable? I heard Professor Mshavela talking about the long COVID. Third question: has the recent February Concord ruling on BEE tenders affected COVID-19 mitigation procurement? Fourth question: given the vaccination rate, how concerned is the department that millions of doses that are due to expire in the next few months will be used up? What strategy is in place to make sure no more vaccines have to be destroyed? Another question: how do we distinguish between long COVID and individuals who struggle to clear infections that persist longer than 7 days stipulated period to clear infections? Another question: has there any training for healthcare workers on how to identify patients with COVID in South Africa? What measures has Department of Health taken to vaccinate undocumented people residing in South Africa? is the Department of Health plan to roll out Sinovac or similar at this stage? I think Dr. Crisp has talked about this, but you can feel free to emphasize this. This is a follow-up to the first questions on Sinovac. Another question: to those who are resisting to be vaccinated after being talked to all in angles, are there any strategies to convince them or to protect them and other people from COVID-19 infection? The last but not least, to what extent are unvaccinated people driving the emergence of subvariants and potential new variants? The very last question reads as follows: is Paxlovid currently available? And if so, what are the criteria for obtaining it? This is the last batch of questions, Minister, Deputy Minister, and fellow panelists. I'm going to hand over back to Minister to allocate and assign this list of questions. Back to you, Minister.
Well, thank you again, Foster. I hope my network is holding. Just quickly, this will be the last. I think the boosters, Dr. Crisp will deal with that. Do we know how many people have long COVID? Professor Mushavela may want to venture into this one. The Concord ruling on BEE, body from our procurement or finance, but I'm sure DG and Dr. Crisp could touch on that. The vaccination law, vaccines, what strategy to make sure and vaccines don't be destroyed. Minister, if you want to venture into this, and I think will be, but I think we can all, maybe let me ask if Dr. Lomo could venture into that. How do you distinguish long COVID and individuals who struggle with? On the platform here, none of us are really front to come into the whether people are struggling from long COVID or just unable to clear the original infection. Training of health workers on how to identify, again, Prof. Mushavelo, maybe, I know you're not on the front desk, but you might be able to share some knowledge from KZU, KZN, undocumented. I think Dr. Crisp, Sinovac, I think it's yours again. Deputy Minister, maybe those who are resisting vaccination, what do we do after all attempts? What then is left to convince them? Whether unvaccinated are driving the variants, I think the NICD team can help us. The DG Paxlovid, is it available? I think let's first start. Let's do it that way, and try to deal with all the questions. Thank you, Dr. Crisp. I think will be leading with the 12 to 17 boosters.
Sorry,
okay.
I'm still struggling to unmute there. Thank you. So in terms of boosting, at this stage, we only vaccinate people according to the approved schedules and the registration by the manufacturer with the regulator. And at this stage, we don't have a registration approval for boosting anybody under the age of 18. So we are not offering vaccination at this point to anybody, I mean booster doses to anyone under the age of 18. That may change, of course, if the registration changes as new evidence becomes available, and depending on what what is submitted to the regulator. These things take time to work out during a pandemic like this, where you don't have all the answers at the outset. Maybe I should just answer the other questions that were allocated to me, and then I'm dealt with. So the other question was about, from my side, the Concord ruling on BEE has not affected the vaccination program in any way. I'm sure the DG can add to that, but for us, it hasn't changed anything. The vaccination of undocumented people has been going on since the beginning. There are a number of complicated factors. The one, of course, is recording the fact that somebody has had a vaccination, so that you're able to know when they are getting a second and a third vaccination. And if you don't have any form of ID or any form of recognition, it's very difficult to record. So it took us a while to get a system, but there is a system, and there have been programs to vaccinate both South Africans and foreign nationals who don't have documentation. Many do, of course, but for those who don't have documentation. The bigger challenge is finding people in groups who are able to come forward for vaccination. So there's a renewed effort, and all the provinces are busy at the moment with programs to try and vaccinate undocumented people. The Sinovac I've spoken about already. We're not procuring any other vaccines because we have plenty in the country, and there's no need to add more vaccines at this stage, as we've mentioned. And perhaps I'll just respond to the Paxlovid. Paxlovid is registered with the regulator in South Africa, which means that doctors may prescribe it, and there are specific conditions that are, as with all medicines, for the prescribing of the drug. It is not on the formulary of the state, and we have at this stage had an evaluation of whether we should include it and go out on a tender or procure it, and the evidence is that it does not add value to what we have. So we are not procuring Paxlovid in the public sector. It's also extremely expensive, but we never even got to the economic evaluation because the committee that deals with the choices of which medicines we add to our essential list already advised us that it wouldn't add value to our system. Thank you very much.
Thank you very much, Dr. Crisp, and thank you, Minister. I think Dr. Crisp has answered the key one on the Concord ruling. What I would just like to mention is that actually the Concord ruling was not retrospective. Hence, all the contracts that we had for the vaccines and for all the other commodities that we use were not affected. There is, however, a system in place where we work with the Office of the Chief Procurement Officer at Treasury if we need any emergency procurement once this matter of the BEE Concord ruling is being managed accordingly. So then I'll request Professor Moshabela to come in on all the long COVID related questions. Thank you.
Thank you so much, DG. So I think in terms of how common the COVID-19 is, in general, I think globally, it just depends on how we are measuring it. When you look at people who have come out of hospital, it's kind of different in terms of prevalence than if you look at people with mild disease. But on the whole, some of the more robust studies that have been done, they show that it ranges between 40 to 50% of people who have recovered from COVID. So between 2 out of 5 people can have, and maybe 1 in 2 people can have long COVID in various forms. And I think what's also important is that vaccination does reduce the severity and the burden of COVID for people that have vaccinated, even after they've had symptoms of long COVID. And in some instances, it reduces that prevalence to about 10%. In South Africa, the study that the NICD did, which is in press currently, shows very high burden because it focuses on people who have been hospitalized, about 67%. But I'm happy, DG and Honorable Minister, to let Dr. Jassat to expand on the study from the NICD. Just to add the last point about the pathology of COVID-19. I think it's very difficult to diagnose long COVID when after people have essentially finished the acute phase of COVID-19, especially because PCR can still detect sort of the virus even after a while beyond sort of the acute phase. And that's why that phase between 4 weeks and 12 weeks, we call it the post-acute phase. And the theories around the pathology really has a lot to do with the damage that may come from infection, the damage that may come from the immunity, some of the sort of comorbidities or interactions with different infections, as well as development of clots in blood vessels. So really, long COVID causes a lot of damage. And as I've shown, it causes damage in many parts of the body. So I think that usually most people will use the cutoff of 12 weeks with the confidence that beyond 12 weeks, most people would have really certainly recovered from the acute infection, except perhaps if they're immunocompromised, but those are unique cases. So it's common and it causes a lot of damage, but through you, Foster and DG, Dr. Jasad can expand on the NIC study on long COVID.
Thanks so much, Prof. Moshibela. So at the NICD, we've been following up patients after hospitalization for up to a year. We telephone them at 1 month, 3 months, 6 months, and 12 months and ask about their ongoing symptoms. And it's really interesting that at 1 month, 88% of people still had persistent symptoms. At 3 months, 66% of people reported persistent symptoms. And even at 6 months, 59% of people say they continue to have symptoms. So the study is still ongoing and we'll report at 12 months what happens. But other studies are showing that there is some resolution by, about a year afterwards. But that's a long time to be continuing to experience these symptoms. And the patients report quite debilitating symptoms. Some have lost their jobs. Some struggle with activities of daily living. Most common symptoms reported are lack of concentration and brain fog, fatigue, shortness of breath, headache, muscle pain, hair loss. So there's a wide range of symptoms, over 50 symptoms reported, and it's quite difficult to make a diagnosis because sometimes they're very vague symptoms and sometimes they're new, sometimes they persist for many months, and sometimes they come and go. And so what's very important is that healthcare providers exclude other causes of the symptoms before they make a diagnosis of long COVID and provide patients the support that they need. They need reassurance that this is real, this is not something they're imagining, and sometimes they need resources, and sometimes they even need referral to multidisciplinary teams, which include specialists, mental health providers, and rehabilitation specialists to support them. Thank you.
Thank you to all the panelists. I'm not sure if a minister wants to make any addition before I hand over to Deputy Minister. Your parting short, Minister.
Well, thank you very much. Thank you very much. I think it's been maybe because we have taken long not interacting with the media and the public. From my side, not to take any further long time, to say thank you to all the participants, the panelists. I think I would want to agree with Dr. Moshibela that at the end, while there is this debate about whether we are in or we are still out of the fifth wave, that it's important in terms of understanding where we are. But what is clear to us is the fact that we must remain on the alert. We must be ready to deal with what is a reminder, as we have always known, that as we move into especially winter season with more people gathering indoors, and possibly also possible new variants, but also as we are all learning about this virus, every time we think we understand more, it comes with a different angle. So it is possible, as it's been indicated, that we may actually be entering this, as Richard also is on this subvariants, such that it is possible that there may be new drivers of the fifth wave. So from a public health point of view, it's and overall also to the members of the public, this is just a reminder that we are not yet out of the woods in terms of the COVID-19, and we must continue to do our best. Thank you very much, Foster.
Thanks very much, Minister, and for that message. And I'm now going to hand over to the Honorable Deputy Minister, Dr. Sentinel. He said he's going to, as he'll be doing the wrap-up, he's going to also touch on that question of those who are refusing to be vaccinated. Over to you, Deputy Minister.
Thank you very much, Mr. Foster. Good morning to the Minister and the panelists who are here supporting us in the department. Yes, maybe let me start on the question that the Minister allocated to me as to how do we deal with those who remain unvaccinated. Under the leadership of the Deputy President in the International Committee and continuously with the Minister when he interacts with the society, he actually uses the term persuade. We want to continue to persuade our people to vaccinate, to take the boosters. Now, this coming into this media briefing today, all the panelists who have supported the Minister are also talking about this matter of this is the only tool that we have, not necessarily to avoid COVID-19 infection, but to actually prevent severe disease and deaths. Now, in the presentation of Dr. Jasat, she also posed that it is this age group of 18 to 34 years that have got less than 35% of a vaccination rate. And that's about 5 million of our South Africans who are in that age, in that group. Now, we would like to really support this to move much higher. Minister, about 2 months ago, was supporting the initiative of the young health professionals and other young leaders and activists in a program called Ready. I am ready to vaccinate. And they were pointing out reasons because they're saying, maybe because it is our own age group that is remaining behind. Can you, Minister, allow us to lead this campaign? And we have seen some positive contribution from that. And we'd like to get the young people just maybe forget about us a bit and then listen to other young leaders, young health professionals talking about this process. We continue to also be on a VUMA campaign every second or third week in a month, but the government has been very clear that we will use a persuasive processes. We will not actually force people to vaccinate. We would like to see South Africans taking this process up because there's an advantage to vaccinate. Now there's vaccination certificate. If you want to go into the stadium, if you want to go to other processes, we support those issues to say, if you want to congregate in big numbers at FNP Stadium, at Moses Mabhida Stadium, really maybe you bring along a vaccination evidence in that regard. But I think as I close, Minister Phahla, supported by these scientists today, have called this media briefing because there are issues of interest that they want to bring to our attention, and they have done so to alert us that if you look into the past 14 days, but mainly the last 7 days, there's signs that are showing that we are getting increasing COVID-19 cases, and they're driven by Omicron of a sublineage BA4 and BA5. We are also noticing increasing hospitalizations and just about 150 in the ICU. The presenters are saying, led by the minister, though it's too early to make firm pronouncements as the severity of the trend of this disease, this must be seen as an alert to all of us. And as you could probably know, the human behavior is such that we tend not to really take heed on some of those issues. So we continue to request that it is not the virus that moves, it's us who move. And when we communicate, we bring along the virus to probably people who do not have it. Therefore, we need to already continue with this request from the minister. Let's vaccinate, let's boost. And in the next 7 days, the department will probably be able to again report to the nation as they see the trend. Thanks to all the scientists and the minister's foresight that at least even if at this what might be an early stage of a fifth wave, we are brought in here to then make the nation alert that please let us actually make sure we watch the space. The COVID-19 is still with us. Thank you very much, Foster, and thanks to the minister for this opportunity.
Thanks very much, Honorable Deputy Minister. Indeed, this rising number of COVID-19 infection should be seen, should signal as a warning sign to most of us, especially those who are not vaccinated and those who are partly vaccinated, that a bigger problem might be coming. And the only way to protect ourselves against this is to do the right thing and vaccinate. On that note, I'm going to take this opportunity once more to thank the Minister, the Deputy Minister, members of the panel, Dr. Yassad, Dr. Richard, and Professor Mushavela, and all other colleagues for being with us today. And I'm going to declare this meeting. Before I do that, I'm also going to thank members of the media for continuous support, giving us their airtime to communicate, to encourage people to vaccinate and protect themselves. And we also want to assure all the members of the media that we are going to avail all our experts, the minister, the deputy minister throughout, in order to communicate this message consistently and regularly. On that note, I'm going to declare this media briefing adjourned until we meet again. Thanks.
Thank you. Thank you.
So,